I think astigmatism management is critical for a successful outcome. I prefer to use the ClearView for my presbyopia-correcting option. So if a patient has even up to a diopter, I feel pretty comfortable doing the ClearView lens. I typically try to make sure that the dominant eye has as little astigmatism as possible. And if the non-dominant eye has a little bit more astigmatism, I think it's a little bit more forgiving.
When we have our patients come in for initial cataract evaluation, we get an eye trace and a Pentacam, and that's going to give us two different modalities of what the corneal astigmatism is. So then and there, I'm confident in whether this patient is going to be a candidate for the ClearView. If they have 2 diopters or higher of SIL, then automatically they're not. But if it's with the rule, then I consider how old is this person. If they're young and they're in their 50s, well then there's maybe a tendency to drift to against the rule over time. So maybe I won't correct with the rule astigmatism all the way with LRIs in a younger person versus if they're 77, 78. And if they have against the rule astigmatism, I might be a little more aggressive. We use femtosecond assisted surgery on all of our premium lenses, so the availability of the laser to make our limbo relaxing incisions is always a possibility. I would use the femtosecond laser in astigmatism with the rule from half diopter to maybe 1 point low 1, and then against the rule, same thing, up to about 1 diopter against the rule. I'm comfortable using limbo relaxing incisions with the nomograms we have to give that patient a great uncorrected distance vision and near.
With the rule astigmatism, up to a diopter and a quarter, because we know refractively it's going to be about 0.75 in the eye. Against the rule astigmatism, we have to be a little more, probably less, because we know if it's against the rule, really 0.75 can be as high as a diopter and a quarter. Now we can do LRIs where you could consider laser vision correction afterwards to tighten those up. But if you're really starting out to use this lens, staying probably, you want to have the ultimate under diopter astigmatism to have the maximal effect of the lens.
Astigmatism correction is important in all presbyopic correction, as you know. And since the lens does not correct astigmatism, I usually limit my range to about a diopter and a diopter and a quarter or less. When it gets to above 1 diopters, I would use a form of corneal correction of astigmatism, such as LRI or femtosecond laser assisted to reduce astigmatism down. Anything under 1 diopters, I just leave it alone, and we'll deal with the astigmatism later if it's present. But when it gets above 1, I usually combine the procedure with some form of astigmatic reduction.